Next. Sterilization during surgery. Phaco sleeve and tip should be cleaned after each and every case. There is no evidence that using antibiotic irrigating fluid during surgery can help, so there is no use of it. Next. Subcon antibiotic given at the conclusion of the surgery is important. Intracameral injection of antibiotic, it has been recommended nowadays, but not in all cases. We can use in high-risk cases. Wound should be watertight. If there is a complication like PCR, we should manage this properly, effectively. Next. Post-operative should visit first day, 7 day, and 15 day, and then SOS. Examination of slit lamp on every post-operative visit is very important. Topical broad spectrum antibiotic for 7 days, oral only in high-risk cases. Topical steroid we give 15 to 20 days in tapered dose. Painkiller is SOS. Protective glass for 7 days we give. If there is infection or doubt of infection, we should talk to the patient and relative and institute prompt treatment appropriately. We should wait for infection to increase. We should start treatment immediately. Do not panic. If you are working in a hospital, you inform the higher authorities. Next, please. This is be covered by other speakers. Next, please. OT layout, this has been discussed by others, but most important is the culture sensitive once in a month. We should create the sample for floor, wall, OT table, and AC and phaco machine, and should keep the record maintained. Next, please. Water tank is very important. We do not take care of the water tank from where the water is coming, but is the most common contaminated part. We should clean the water tanks very frequently. We should have separate water tank for our OT. Next, please. This is a very important checklist. Every week, daily, weekly, and monthly. Daily checklist, who checked the pre-operative medicine, who checked autoclave, strip register, who filled the drum, who checked clarity of the injection, who did preparation of the patient. These are important things. We should check it daily. Next, please. Who cleaned the equipment, who put on the ULID, who replaced the bed sheets. This should be made outside your OT wall, signed by the OT nurse who is in charge, and should be signed, countersigned by the doctors. This helps your staff to be kept on the toe. They are aware the doctor is going to sign it. They are going to know what care they should take care of the OT. There will be no negligence now. Next slide, please. These are weekly checklists. List of medicine, who checked it, who checked the expiry, who submitted autoclave report, who did the cleaning on Saturday, Sunday, who cleaned the wall, who cleaned the sink. They should also be signed by OT staff and countersigned by doctor. Next, please. Who cleaned the instrument, who cleaned the ACs, who cleaned the scrub area. These all things are mentioned and signed. You keep in the file. This will help also you in the court of law when you can show them, the judge, that you are taking all the precautions and very precisely. Next slide, please. Who checked the expiry date of medicine? Who cleaned the microscope? These are the weekly checklists. Next, please. And this is the monthly checklist. Who tried the soft culture from the OT? Who cleaned the OT, all the furniture? Who didn't charge the waste, washing of the OT on last Saturday? These things are always helpful, keeping your staff on toe and making aware that they have to check it. Next, please. Who cleaned the drum? Who cleaned the windows? Who cleaned the storage shelf areas? And everything should be signed and documented, kept in the record. Next, please. If you take care of all these things, next day your patient will be smiling, and big thanks to you. Thank you, Dr. Savachi. Thank you, Dr. Nimble, for including me in your instruction course. Thank you.
So thanks, Dr. Sathanshu, for the nice and brief presentation on these things. And what you have again re-emphasized, the daily, weekly, and monthly schedule has to be maintained and to be properly documented also. Unless you document, no one is going to believe what you are doing or not doing. So for your safety purpose and for medical legal purpose, all the things have to be properly documented. So now we are going to have the presentation on documentation by Dr. Santosh Mahapath. Dr.
Thank
Santosh,
you.
please.
Thank you, Dr. Patnaik. I'm really privileged to be part of this session, and I thought this is the most difficult presentation in the series. But now I feel this has become very easy for me because most of the things have been covered by Professor Subodhi, Dr. Patnaik, and Dr. Mathur, and following me, there are stalwarts like Dr. Sumina and Dr. Nirmal. So I feel a little relaxed. I have no financial disclosure. As you can see in the list of the things already, OT complex design is covered. Disinfection process in OR and equipments covered by Dr. Patnaik, and sterilization process is also covered. I'm coming to the validation of sterilization. Yes. So sterilization is, as you all know, is the process where all the microorganisms are killed, including the bacterial spores. And for documentation purpose, we should understand what is a sterility assurance label. That is reduction of anticipated levels of contamination into a load to a point where probability of survival of any organism is less than 10 to the power minus 6. And this is the sterilization cycle. You can see starts with cleaning, and very elaborately Dr. Patnaik has clarified in which way the instruments should be cleaned. And after cleaning, it has to be air dried, either by a blower or by simple room air drying with AC on, and all the surfaces needs to be exposed to air so that a proper drying is maintained. This drying also applies to not only the instruments, also to all the surfaces on the OT, including floors, tables, and trolleys, etc. And third step is sterilization, where you need to pack the instruments properly and then go for sterilization either by dry sterilization or the steam sterilization. And after sterilization, the instruments need to be properly stored and labeled. And each person responsible for each of the things should have a fixed responsibility, sign a register as discussed, and storage packages needs to be properly inspected before being used. So utilization is a process where all the stored items which are already sterilized are going to be utilized inside the OT. Then after utilization, the same process of cleaning, drying, sterilization follows in the cycle. This is called the sterilization cycle and need to be well documented with SOP for each OT. So this is the most important backbone for each OT. Theater sterile supply units should be well maintained with clean zone and utility zone and inside OR. All these units need to have fixed persons responsible, and once they are contacted, they need to come to the next zone to receive the instruments, and then the flow of instruments goes like the way I just discussed in my previous slide. The sterilization method already just described by Sabyasachi Patnaik and includes both steam and dry heat. The steam is...
Sir, may I request you kindly conclude in next 30 seconds?
No problem. There is time.
Yes.
Continue. Continue.
He just started. So let him continue. Please
your
carry
timer
on.
is not set. Your timer is not set.
The steam sterilization is usually autoclave with times of 150 degrees centigrade for 25 minutes and is usually lethal to all the bacteria, viruses, and spores. And all the linens and metallic instruments are sterilized with it. But the disadvantage is it needs to be, the items need to be heat and moisture resistant. This is the most commonly used sterilization method in most of our ophthalmic OTs, followed by ETO. This just dry heat either in 5 psi for 12 hours or 10 psi for 6 hours. Advantage is that it works in a lower temperature, but disadvantage, it is toxic to humans and it can be explosive sometimes. But it is very useful for heat labile instruments, tubings like phaco and vitrectomy cassettes and probes. And the third one is a plasma activated, which is usually not used in most of the time. So coming to the validation of steam sterilization, the qualification and calibration are most important. Complete removal of air from the chamber and replacement of saturated steam is the key principle on which this works. The older models use gravity displacement system, and the newer models now use the cycles of vacuum and steam pulses to increase the efficiency of air removal. The selection and calibration of thermocouples is very important because accuracy of thermocouples are the backbones on which this validation process depends upon. And a degree up to 0.5 centigrade in thermocouple accuracy is needed to validate the sterilization process. So there are different indicators as discussed previously, and the biological indicators usually are not clinically very commonly used, but they can be spore strips or self-contained vials or spore suspensions, which can be used for different process of sterilization. Autoclave indicators, there are 6 types, but class 1, 2, and 3 are the most commonly used. Class 1 is indicator tape. Class 2 is Biomedical testing, and class 3 is used for ETO. Chemical sterilization usually not commonly used, but whenever it is used outside the operation theater, the indicator needs to be well red and it should be a deep blue in color. This is the most commonly used strip in autoclave, and before the autoclave, this is blue. The strips are yellow in color, which must turn to deep black. Anything in between color is not acceptable, like brown or low intensity black colors are not acceptable because they indicate incomplete sterilization. And they have each, after sterilization, one person need to enter it into the registration like this and sign it. The pre-sterilization evaluation of autoclave, the most commonly used is Biodiverse Test, and it is mandatory for pre-vacuum sterilization and has to be carried out on daily basis. And these are the different ways which you can see. This is the where they are uniformly colored, and the colors are not of very dark like this or very light like this. So rest are not good. Like you can see in blue at the center. This is superheated with steam, blue at the periphery. So these are not acceptable. This is the most ideal color and should look for. The pre-sterilization evaluation, sterilization vacuum performance is acceptable if sit inside the test package so uniform color. And on the surface also, it has to be red. ETO is now the most commonly used sterilizer for most of the operation theater. It consists of 5 cycles: gas introduction, evacuation with humidification, exposure, evacuation of the instruments, and air washes. And here we don't validate the microorganism death, but the endotoxin challenge vials are placed in cold spots of the dry heat oven, and they are compared with the ones placed outside. So in the validation process, one must verify these data. What is the concentration of ETO released in the vessel? What is the concentration of water vapor in the vessel? What is the range of temperature distribution? How much ETO consumed during the cycle? What are the rates of creating vacuum and pressure? And does the selected cycle sterilize the product fully? And all these questions need to be answered and documented on the register. This is a pack from our OT. This is the pre-ETO pack. You can see the color of the ETO strips at the periphery. You can see the color change, which is very well seen here. And these are usually used for vitrectomy cutter like this, or a phaco tip. And the validation report must, it's the common element for all the reports, with an identification mark that with a number, and a protocol reference should always be placed. A brief summary of the range of operational conditions should be mentioned, with a brief description if there is any deviation from the usual process mentioned in SOP. And there need to be a conclusion line, and all reports should be reviewed and approved by the hospital authorities. So all OT should have SOP for everything. Role and responsibility of each healthcare worker, maintenance of registers, maintenance of the sterilization cycle, protocol for sterilization failure if it happens anytime, and protocol for biomedical waste management. I'll just show a photograph of two of my OT registers. This is a register, ETO register, where each thing is mentioned, the person who has packed it, and the items packed, verification tag which is put after the instruments come out, and sign of the person who has verified it. Like that, this is another register of OT cleaning and fumigation register. And this is, you can see the date is mentioned, that 14th May 2021. We have 6 OTs, OT 1, 2, 3, 4, 5, 6 is mentioned. And the person who has done the cleaning and fumigation, is the name is mentioned, and it is verified by me either weekly or monthly.
No, that is to be done daily.
Daily basis, they do it daily basis, but I countersign it every week.
No, that is correct, but it is surgeon's responsibility to verify that everything has been done properly in the same day.
There is another paper which is being signed by each OT surgeon.
Yes.
Inside the OT.
Yes.
The protocol for sterilization failure also need to be very much outlined. Take the sterilizer which caused a failure out of service. Collect all items sterilized since last negative spore test, and re-sterilize the items in another sterilizer. Review operation protocol of the sterilization. Operator error if it is suspected, then reset the sterilization and observe the cycle again. And the spore test, if it is negative, sterilization can be reused, but if it is positive, definitely you have to repair or replace the sterilization. Biomedical waste management, we all know there are different colors for different items, and this is how we maintain it in our OT. And this has to be followed in this cycle. We should have in-house segregation of all items. There should be a common place for storage point, and it is transported by usually in our hospital, we have given the responsibility to SANICLEAN, who does the transportation and unloading in different units, then treatment and disposal. So this covers most of the part of it. So the proper validation and documentation of sterilization process is the prerequisite for any infection-free operative procedure. Hence needs to be well maintained following SOP of each institute in adherence with the NABS guidelines. Thank you.
So thanks, Dr. Mahapatra, for this excellent presentation on documentation. What we have discussed so far is sterilization procedure is important, and along with that, the documentation of everything is very important. So we have to, as Dr. Satanshu Mathur has explained in detail, so what are the steps, and again, who is the person assigned to do that? So that is also to be mentioned and to be monitored daily, whether it is properly done or not. And as the head of the institution, Dr. Santosh Mahapatra has rightly verified weekly or monthly the entire register, whether it has been properly maintained or not. So these are the things. Our essence of giving the message to all the audience is you have to do properly and also document it properly. So this is what we want to emphasize. Now we have Dr. SAMINA Jamindar with us. She is acclaimed specialist on these issues and NABH accreditor also for most of the institutions of the country, and she is a well-known figure in this line. So now I request her to give his presentation on patient safety and as well as staff safety. In this COVID time, this is also very important that our staff also remain protected for any infection. So how is that is to be taken care of? Dr. Samina Madam.
Thank you, Dr. Sabyasachi Patnaik and Dr. Nirmal Frederick for giving me this opportunity to be a part of this very important instruction course. Um, so this is the scope of my talk. In the first part of the talk, I will be talking about the safety of patients and staff in operation theater. And in the second part, I will be talking about special measures to ensure safety while reopening your operation theater amidst the COVID pandemic. So friends, these are the patient safety guidelines, which has 8 very distinct goals. Goal 1 is to reduce the risk of healthcare associated infections, about which this entire IC is focused. But when I am talking about safety, there are many other aspects which become a part of safe protocols. This goal 2 is improve effective communication and handovers. Third, surgical safety. Goal 4, medication safety. Goal 5, patient fall prevention. Goal 6, patient identification, correct patient identification. Goal 7 is a culture, a safety culture, where there is all adverse incidents are reported. And goal 8 is to have rapid response teams and have risk readiness for any risk which the organization might face. So while we are talking about reducing the risk of healthcare associated infection, hand wash, use of PPE, and needle stick injury protocols are the most important when we are talking about safety inside an operation theater. Your staff needs to be trained and be aware about the adverse effects of a needle stick injury. And vaccination is something which all your vulnerable staff should have for hepatitis B. There is always a risk of HIV after needle stick injury, and hence there should be clear training about what has to be done and what is the post-exposure prophylaxis according to the NACO guidelines. This awareness and training is very important, especially in your housekeeping staff who cleans the operation theater. They might just ignore a needle stick injury, and they are the most vulnerable people who will not worry about such small injuries without knowing the actual consequences. So the onus is on the surgeon to do this. These are the PPEs now what we have during the COVID era. Improve effective communication and handovers. Communication is a very important topic, and I take this opportunity to welcome you to our instruction course on Sunday at 6:30 p.m., which is completely dedicated to communication in eye care. And we will be discussing in details. But remember, you need to improve effective communication and all critical communication in your operation theater. Pre-op instructions, post-op instructions needs to be documented, and the patient should be signing on that. That is very, very important to save you even medical legally and have a very crisp understanding of what has to be done and what need not be done. The communication in COVID times also can be done with proper social distancing and protocols. When we talk about staff, we have to understand that they are the most important resources in any hospital. And staff in operation theater are the real warriors. They are the warriors of our theater-based sterile surgical units. Not only they need to be trained, they need to be empowered also. If there is a sterilization failure, if one of those indicators has not worked, if your physical parameters of autoclave has not worked, if there is some problem, they should not have the fear of penalization. They should be empowered to report a sterilization failure. There should be an escalation reporting process map, which is very clear in the operation theater. This is the only way you can avoid any major tragedy in your operation theater. Empower, respect, and train your staff all together. This gentleman, Dr. Atul Gawande, has been talking about surgical safety checklist for many, many years now. And we are such proud Indians that an Indian surgeon was the one who surgical safety checklist to WHO, and WHO sort of made it mandatory for most of the surgical institutes to have this. Sign in, time out, and sign out. Sign in before the incision, time out, before the procedure, sign out, before leaving operation theater. Things needs to be checked. It's not just a checklist. It's like a drama to be played out in the operation theater with every patient. So the timeout procedure and the site marking before every surgery becomes very important in our most commonly done surgery, that is cataract surgery. Take a timeout immediately before starting the procedure to perform a final check to make sure that the correct patient is about to undergo the correct procedure on the correct site and the correct implant. Safe anesthesia becomes very important. We, most of the time, cataract surgery is done with topical anesthesia. Nevertheless, preoperative evaluation of the patient and immediate preoperative re-evaluation of the patient becomes very, very important. There might be some medication which the patient has not taken before surgery. There is an allergy which the patient has, which has been forgotten. The vitals of the patient immediately before the surgery, these become very, very important. And you need to have, as your hospital's policy, which kind of patients will you allow in your operation theater. There is this American Society of Anesthesiologists guidelines, grading 1, 2, 3, 4, and you decide as a policy, are you equipped to handle a grade 3 ASA? Or you will be now say, no, my hospital, I will take only these kind of patients. It's very important in conjunction with your anesthesiologist to have an anesthesia policy, especially in an ophthalmology operation theater where medical emergencies are rare. But when they are rare, your readiness should be very high because your experience to deal with such emergency is less. Medication safety, very important. LASA medication identification, labeling them and storing them separately, especially those medicines which are a part of your emergency drugs. High alert medications, again, label them and store them separately. 100% reporting of medication errors, including near misses, is very important. When Dr. talking about registers, I would request a register for adverse event monitoring also in the operation theater. That becomes very important. Every adverse event in the operation theater, in any ways, whether it could be a part of your surgery or anesthesia or sterilization, should be reported, a corrective and a preventive action taken. Expiry dates of the drugs, disposables, so many things what we use in the operation theater should be decided and followed. You can make a simple Excel sheet and stick it. Refrigeration, which happens for some of our medications, the refrigerator temperature is so important because if the medicines are not in its correct form, again, intracamerally, it's going to give you a very bad reaction. Incident reporting culture, I have already spoken about it, that is very, very important. And we should encourage an incident reporting culture in our hospitals. That is the only way in which we will be able to eventually improve quality at our hospitals. A rapid response team for basic life support, something what we call it as a code blue team, should be ready. And the team is trained with all emergency equipments and medicines available in your hospital. Help the patient more effectively without panic and call for appropriate help. And such mock drills should be conducted. NABH, of course, makes it mandatory, but with or without NABH, friends, I would recommend that you do have such rapid response team, get the basic life support trained, and see that you do have mock drills also. This is one form which should be available in your operation theater. Tomorrow, if you have a death and you have not called for a code blue and you have not filled the minutes of the code blue, you will be in a big soup. You would have done everything, but you have not documented that you have done this, is something which is going to really cut you a sorry figure in the court of law. Now I come to the second part of my talk, that is safety of patients and staff in operation theatre while reopening your operation theatre amidst the COVID pandemic. Staff safety is very important. Your HR has to be strong and see that the OT and the OPD teams are separate and they should not mingle. The patients and attendance for the OT and OPD should not mingle. The timelines and punctuality is very important in a COVID pandemic because you don't want a single person to wait unnecessarily at your hospital. And training for all safety protocols should be ongoing. Monitoring the health of your OT staff regularly becomes your responsibility amidst this pandemic. Ensure good functioning after lockdown for OT infrastructure, for OT equipments, OT instruments, and water system. Of course, your infrastructure, if you have an air handling unit, and you need to check for the HEPA filters, for the temperature, the humidity, and the terminal cleaning. Biologist Dr. Satanshu already spoke about it. I would also request to do sedimentation plates, that is as a passive culture. Plates are very, very important. Check for all emergency equipment, medicines, and oxygen, whether they are present in your OT before you decide to start your operation theatre. Water system already mentioned. OT equipments, yes, the functioning of the OT equipments, all the equipments. A routine maintenance should continue while the OT is still not functioning, and then preventive maintenance to be called for before you start your operation theatre. Instruments should be all removed from the packs, washed and dried, and then reused with repacking. OT disposables, again, please once again do an exercise of checking all for expiry dates, damages, and any openings. Friends, I'm going to leave you now with these words by Thomas Carlyle, that our main business is not to see what lies dimly at a distance, but to do what clearly lies at hand. While we could not hold hands during this pandemic, we hold hearts and take our team forward and go ahead. Thank you very much.
So thank you, madam, for your excellent presentation and highlighting the most important things that we have to observe, definitely, because we cannot take chance. Now, I want to ask one clarification regarding that code blue form that you told. So what exactly that it contains?
So if there is a case of a cardiac arrest and when you do CPR,
Yes. Okay.
you call for a code blue, right? And when you are doing CPR, the minutes of the meeting of the CPR has to be noted down in this kind of a format, what is known as a code blue form. And that form, the format should be available in your hospital and it should be noted down, because even if there is any death in the hospital, which can happen, if you can prove that you have called for a code blue, you have a CPR was done, and you've tried your best to save this life, that form, filled form is the proof, the document.
Because I had the experience of death in not inside OT. The patient was operated on very quickly. 5 minutes it took the surgery, topical. Then patient went to the ward, rested for some time, and when he was preparing to go to his home with his son, then suddenly he started coughing. Then he had 4 or 5 bouts of severe cough, and then suddenly he collapsed. Fortunately, we had this ICU inside our hospital campus, cardiac ICU. There he was admitted and declared dead. So I couldn't understand what was the reason. He was not a hypertensive. There is no risk factor for that. So this thing what you told also, we have to maintain that record. We know that. So this is a new thing for all of us. I think we have to follow this. So now we have Dr. Nirmal Pedri to present to us the guidelines as per the NABH requirement that we should follow, because there are many confusions in our mind also. We should whether we should have a modular OT, every surgeon should have, or we should have AHU or not, then what type of autoclave to be used. So as per NABH, what are the things that we must or we have to follow? So I request Dr. Nirmal to highlight on those issues for the benefit of all the delegates.